Thank you for attending today. I will now introduce our facilitator, Dr. Randy Longenegger.
Hi, everyone, and thank you for joining our webinar today. Very interesting topic, introducing diverse clinical learners into diverse rural communities. This is the first of our professional development webinars over the summer months. We will be having another session again next month and in July as well. Today we're happy to have Dr. Godzik from the University of California, Davis with us. And Davis Patterson and I, as facilitators, will facilitate the question and answer portion of this webinar. Following a brief introduction to our session today, Dr. Godzik will proceed with a presentation, and then we will involve you as audience, hopefully for 20 minutes or so in the second half of the hour. The Rural Prep is a collaborative for rural primary care research, education, and practice. It's a collaboration among 3 medical schools in Washington, North Dakota, and Ohio. And we are funded by HRSA to conduct research, develop a community of practice around rural health professions, education, and training, and disseminate evidence-based practices. These professional development webinars occur 4 times a year, and they're intended for educators, researchers, whether faculty, students, residents, or others. And we hope you find them useful as you develop your own abilities as a teacher or as a learner. Today, we are particularly going to talk about staffing needs of rural communities and the ways in which trainees can be integrated into healthcare in these rural places. Because learners come with their own ethnic background, their own place they grew up from, etc. And they come to a place that, surprising to many learners, is also diverse. Rural isn't the monolithic place that it used to be, if it ever was. And it's important to help learners in this environment. Dr. Godzik is going to share with us some tools and methods to make the experience rewarding and inspiring for both the learner and for patients that they care for. So without further ado, let me introduce Dr. Godzik, who will share her screen now. She is from Sacramento and can tell us more about herself as part of her introduction.
Thank you for that lovely introduction, and thank you both for all that you do and your team. This is a very important work that I think that is under recognized and appreciated. So I appreciate you inviting me to participate in this important topic. I met Davis and his team at a dinner in Sacramento where members of grant recipients from the HRSA grants around diversity in the workforce and in medical education were grouped together, and we had an absolutely lovely dinner where I shared some of my personal experiences as someone who had entered rural practice soon after graduating residency, and I spoke about what my time was like in rural settings, and then I spoke a little bit about my work with learners. As an educator, I had the opportunity to talk about and think about how best to integrate learners into a variety of settings. And this is a picture of my brother's dog, Holly, who was visiting from the big city and visiting me in Fall River Mills, which is a tiny town of 500, well, a little bit over 500 people in Northern California, where I was working in a setting that was very rural and where the population was primarily ranchers and agricultural workers, and I love this image of this city dog trying to figure out what those creatures down below are and trying to figure out where she fit in. So it just kind of speaks to the experiences that some learners and new professionals have when they enter a rural setting if they're not familiar with it. So what I'm going to do today is go over those goals and objectives that Mandy mentioned. I really want to provide you a mix of a review of the literature around issues of diversity in rural settings, but I also want to give you some practical tools so that you can think about how best to have a diverse workforce serve the needs of rural communities, and recognize how that can really be of benefit to everyone involved in that. So just really briefly, I'm going to review the scope of the need in terms of rural settings and how much primary care physicians who provide up to 40% of all medical visits provided in healthcare in general. Unfortunately, less than 12% of primary care physicians in the United States choose to work in rural settings, despite the fact that over 20% of the population lives in rural settings. So there's a definite mismatch, and the result of that mismatch is really significant health disparities. And that difference here that you see between the light and the dark brown is preventable deaths that occur in rural settings. We think that they're related to many, many factors, but there's no doubt that access to healthcare is a big proportion of where this excess number of deaths is happening for these populations who are in non-metropolitan areas, and this is top 5 causes of death. If you haven't already, one of the lovely ways to explore what your county's challenges with rural health are, you can go to this Rural Health Info Hub website, which will provide you with an opportunity to enter your own zip code and review disparities in healthcare, be it with healthcare providers, with outcomes, with staffing, including mental health, dental health, nursing staffing, etc. So my screen is not advancing for some reason. Let me see. I'm not sure if JP is around to see if there's something going on with or if we need to use the saved version of the PowerPoint that you have.
I'll do that, Michaela.
Yeah, it's just not advancing. So if you have, that version, that would be great. Okay.
Let me.
Sorry about that.
That's okay. That's why we have a backup. All right.
I think we were on those lovely blue bars. Yes.
Yeah, let me just move things out of the way so I can see what I'm doing. All right. You'll just tell me next slide, and I'll be happy to advance it then.
Thank you. All right, next slide. And again, this is data that you all know, but just to review briefly, the challenge going forward is that these numbers are not going to get better in terms of who's going to be available to provide care for rural populations. Almost 50% of non-metropolitan area primary care physicians are over age, or physicians in general, not just primary care physicians, are over age 55. So we're really entering a challenge where we need to figure out how are we going to get providers for these communities. Next slide. So really briefly, thinking about a few solutions for workforce shortages. The bulk of this talk is, of course, about the third part, but just to review briefly other opportunities for thinking about workforce shortages in rural settings. I think that the idea of pipeline programs is well understood by many, and I think it is actually underutilized in general in terms of thinking about how to expose K through 12 students early on to medical practice and have them think about it when they might not have it in mind because their family might not have anyone who has done healthcare work in the past. And I'm thinking about it particularly because I recently ran into a classmate of mine from UCSF where I went to medical school, and I actually knew part of her story, but I hadn't realized that she was the child of migrant farm workers who moved around every season, going from area to area in California to orchards, to asparagus fields, etc. And there was a town that she was in, the town of Quincy in California, where a teacher took a shine to her when she was around 8 years old and took her to a medical clinic locally, and it made all the difference. This is someone whose parents hadn't finished middle school, who were monolingual Spanish speaking, and that opportunity that her teacher exposed her to got her to UC Davis for undergraduate training, and then to UCSF for medical school. And she now works in a town of 7,000 people in Southern California. And so I really would encourage you to think about what pipeline programs to integrate K through 12 learners and expose them, be it just a half day a week in the medical clinic. If you have 30 students in a class, doing that over the course of a year, a half day a week, you could get every single one of them to have individualized attention with a primary care physician and understand what practice medicine is about, and hopefully have them fall in love and think about doing that in the future. So that's one method. The other thing to think about is unique training programs. One of the things that was noticeable when I was in, I've worked in a couple of critical access hospitals, is that there are opportunities for critical access hospitals to develop unique training programs that are needed by metropolitan areas. Things like running an ALSO course or an ATLS course or even a BLS course, and doing that if it's an hour and a half drive away and it's done in a time that's convenient for people over the course of the weekend, and you do that on a regular basis in a place that seems to have a dearth of those courses available, you can really have metropolitan area facilities and healthcare providers from metropolitan areas understand that you have unique areas of skills and expertise, and you can really support your local providers in feeling empowered and able to provide needed training and have a lot of crosstalk that otherwise might not happen just by holding these regular courses that are needed by people in different environments, and that way introduce them to your rural community. And then finally, the bulk of this talk is about how to integrate learners in training to expose them to rural communities. You can advance that slide. Is that moving? There we go. Thank you. So one of the strategies that medical schools have used, and Randy is actually an expert in this, to develop rural providers, is to develop rural training tracks in medical schools. And the brief review of what those rural tracks are looking for in terms of who is someone who they are going to invest in and take the time to dedicate resources to over the course of their medical training are listed here. And I think it's interesting to see that, you know, rural interest and background is of course a big one and main one, but also character, and we'll talk a little bit about what that character is, and that's also work that Randy has done that we'll review in a little bit. You can go ahead and advance that slide. So, you know, when you think about opportunities for learners to be exposed to rural settings, if they're not in a rural training track, how do you have them understand what rural practice is about? One of the ways that you can do this is through isolated clinical experiences, but they're actually pretty labor intensive. Usually these labor intensive isolated clinical experiences involve the learner having a period of figuring out where they can go. They have some sort of contact in a rural setting. They create a connection there. They set it up. It may or may not work with their schedule. Those of you who are educators at the graduate medical level in family medicine know it's actually quite challenging for family medicine residents to have time away from their home program for a variety of reasons, mostly the ACGME's requirement that family medicine residents spend 40 weeks out of the 52 of the year at their home clinic. And when you factor in vacation and night float and all of that, that doesn't leave a lot of time for them to leave their home clinic and go out to a rural setting. So all of that coordination is challenging. And then you have to have a receptive person at the other end. And we'll talk about what it means to be someone who supports a learner at the other end. But again, if you are relying on a motivated learner and a champion on site, a physician, these isolated clinical experiences, unfortunately, can often fall apart without a lot more intentionality and system support. You can advance that slide. So we're talking a little bit about who ends up in a rural setting. There's great data that consistently shows that people who grew up in a rural setting, specifically people who went to K through high school in a rural setting, end up in rural environments. And there's something about those formative years and understanding what it is like to live in those settings, which make people feel comfortable going back to them. So that is an obvious focus, is figuring out, you know, who are these people and have they had an exposure to it that's been sustained in their childhood, and trying to focus your energy on that to get them back to the rural practice. Beyond that, there's other really good data showing that people who have a rural rotation or a rural residency do tend to go back. And then finally, people in family medicine or primary care training. I think it's notable when you do the review of these studies that actually gender, race, educational debt, international medical graduate status do not seem to have that strong of an association. There's a very weak association with the debt load and the IMG status, and who ends up back in these, and who ends up in rural settings. But these three that are up there really seem to clearly correlate with who ends up in a rural practice. Go ahead and advance that slide. So, so when we talk about diversity of the healthcare force and we think about who really ends up in rural settings, I think the conventional view is that it's a married white man who ends up being the Dr. Welby type of do-it-all doc in that setting. But I think these numbers are really important to review. And that is that underrepresented in medicine physicians, URM physicians, actually provide a very important bulk of care for the underserved in general, and be it in health professional shortage areas, in medically underserved areas, they tend to gravitate towards serving populations who have a significant need and where they are the doc. And so if you look at these numbers, I don't unfortunately have access to the cursor, but close to 45% of all Black physicians end up practicing primary care. Over 40% of Latino and Hispanic physicians end up in primary care. And then in terms of who ends up in medically underserved areas, those numbers are also significantly higher than what you might see in other racial groups as categorized by this review of the literature. And I think it's really notable when we're thinking about who is the workforce who's going to provide care for underserved areas, which all rural settings are, as we reviewed before, that there's a dearth of physicians. These physicians, URM physicians, gravitate towards providing that care. Go ahead and advance that slide. Thank you. And then drilling down to the actual numbers, this is a review with odds ratio of what is the likelihood of Black physicians and Hispanic physicians providing care to certain groups versus white physicians. Low income patients have a 2.0 odds ratio, increased ratio of receiving care from a Black physician versus a white physician. And that's 1.92 for Hispanic physicians. There's also a slight increase for Asian physicians. Similarly, Medicaid recipients have a significantly increased odds ratio of receiving care from underrepresented in medicine physicians. With marked notable odds ratios. And then finally, for non-English speaking patients, they also tend to receive care from URMs. The numbers are quite striking for Hispanic physicians with an odds ratio of almost 18. So these folks, the URM folks, who are sorely underrepresented in medicine, provide a disproportionate care for the most underserved. Can you move to the next slide? So this is an interesting map that looks at how underrepresented in medicine physicians distribute geographically. And so the darkest areas are where there are the most URM physicians, and the need in those areas is met predominantly by URM physicians. And the next slide, Randy, if you're able to toggle back and forth between them, is those HPSAs, so those health professional shortage areas. And if you go back, sorry for that, you see that there's a significant overlap of where the URM physicians are providing a disproportionate amount of care compared to non-minority in medicine physicians. And how that plays out is that these areas of significant need will have a higher percentage of underrepresented in medicine physicians. Stay on that slide for a sec. So the blue portions are metro areas. The green portions are rural areas. And so, one might wonder, are these URM physicians ending up predominantly in metro areas? And it doesn't seem to be that clearly defined. Toggle back to that URM map, the black and white one. So if you look at that southeast corridor, there's actually significant overlap with rural areas. You look at the Dakotas, that was all rural. There's definitely some representation here from the URM physicians. The kind of Pacific Northwest areas, those are also rural areas. So you know, I think that traditionally we've thought, you know, ethnically underrepresented medicine, racially underrepresented medicine physicians end up in metro areas, and so they don't go rural. But I think that there's that is not actually true, and these maps kind of demonstrate that. Go ahead and go forward. Yeah, so thinking about where these areas of a rural setting. This is from a lovely paper published in Rural Sociology that reviews the changing demographics of rural settings over the last 20 years. And so if you look, all non-metro includes micro and rural, so that's just kind of the density limits. I'm not sure actually what the cutoff they used here is for the density. I think it might be under 10,000, but regardless, if you look at the top bar, which is all non-metro, there's a significant trend towards a decrease in these rural areas being predominantly white. They're still, you know, significantly white with almost 70%, or sorry, more than 70% in 2010, but versus the 80% plus in 1990. And where are those numbers coming from? If I had the cursor, I'd kind of run it over those white areas in the bars. You look at those white bars, and that is the Latino population. And so the numbers of Hispanics in this country continue to grow, and they have been steadily increasing throughout the country and in rural areas. And so the proportion of other is also increasing. But you're thinking about where are the changing demographics coming in from rural settings, and part of it is an increase in Latino patients coming from Central and South America. You can advance that slide. So thinking about what that means for us as we're looking at students and what we need for our physician providers, the green shaded ones are include Black graduate medical.
I'm sorry, Michaela, can you hear us still?
And it'll be it'll be over 1 in 4 by 2050. And those numbers of Hispanic medical students isn't budging. It's not really moving. It hasn't moved since 2000. And we need to do better in terms of having our medical students really match the needs of our diverse population. And these numbers are pretty stark and demonstrate where the need is. And then, of course, for Black physicians in the Black population, though there isn't a significant change in the Black population, the numbers of Black physicians who are providing care is starkly mismatched with the population. Can I advance that slide? And then finally, you know, these numbers that I'm showing you here are a broad paintbrush, really, you know, Black population versus Latino population versus white population. communities are much more diverse than that. All communities are much more diverse than that, and rural communities are not excluded from their own diversity. And so this is a review from that same article I mentioned of the diversity of some different small towns, including Elizabeth City in North Carolina, Barrow, Alaska, Lihue in Hawaii. And you look at these proportions of what diversity means in those areas, and they're radically different. You know, is it a predominantly Black community, but it's still rural? Is it a predominantly Native American? And all of that diversity of the local population means that we have to be thoughtful as we support our learners in being able to work in these communities. Go ahead and advance that slide. So here's part of our challenge when we're thinking about how to educate those learners to be prepared to work in those diverse communities. 92% of all of our graduate medical education for family medicine physicians takes place in urban settings. Only 7.5% takes place in rural settings. So how do you have our learners be ready for it? And I'd like to bring up my own example. I was trained in an urban setting. I lived in urban communities for my entire life. And I gravitated towards training in a family medicine residency that was full spectrum, where family docs were the only residents in the county hospital where I worked. And Randy, if you can go to the next slide. I pulled out this slide of data from work that Randy actually did, where he surveyed providers in rural settings and in urban settings and asked them, based on data that had been taken from STFM, a task force that reviewed what characteristics are unique to rural practice. And these 6 characteristics of identity or of character, as I was mentioning earlier, were identified as being important, more or less important in or unique to rural settings. When I think about my family medicine training and what it provided me with, I think that it emphasized some of the things that are unique to rural practice. Even though I was in an urban setting, the adaptability of family medicine was something that our residency program and our attendings emphasized to a point where it was a core value of the actual training, despite the fact that we were in a relatively urban setting. And also because we were in a full spectrum county healthcare system that was basically run by family doctors, we worked in an environment of scarcity where the family docs were providing a lot of the specialty care. And being able to do that comprehensive care, and having the agency and there's a sense of pride in having the courage to run the ICU, to do your C-sections, to put in lines, to feel comfortable intubating newborns, preemies. And all of those things are actually values that overlap profoundly with the rural practice, things that are unique to rural practice. And I think that there are ways that urban training programs can emphasize values that really can be important when it comes to the practice of rural medicine. You can advance that slide, thank you. So go ahead and advance again. So thinking about how you're going to welcome your learners into a rural setting, and why, since we've reviewed the why, how you do it. It can be done at the undergraduate medical education level, and that's where your medical schools can provide information about the surrounding rural environment through things like taking bus tours to local communities, reviewing the local healthcare, public health data around what the demographics are, review the history of a community, understanding why certain demographic groups ended up in these communities, even though they might not have been, there for hundreds of years, but maybe they've been there for 30 years, and is that related to, economic changes in the region? All those things are really important for schools to provide to learners so that they understand kind of the waves of demographic changes in the communities that they might serve, and that they have some context when they're working with their patients. Can you advance that slide? Yep. So how do you have your learners be able to incorporate this information in a way that is thoughtful? A couple of decades ago, we used to have this notion of cultural competency. You can find books that have chapters on the Hmong patient, the Nigerian patient, the Native American patient, big bucket terms, and there would be a list of things you were supposed to know about these populations. And while well-intentioned, it was, one can imagine, quite reductionist, and might miss really important things about the unique patient that you had in front of you. And so over time, over the last few decades, we've developed the notion of cultural humility, which is really more a way of approaching patients. And teaching your medical students how to do this early, before they go out into practice, can give them the ability to work with a widely diverse population and be ready to take on the diversity of experiences that they might encounter, and the diversity of patients. And so you can advance that slide. The notion of cultural humility was developed by Jean-Marie Garcia, who's actually at UC Davis now, and Melanie Turvalon, who's at UCSF, and they describe that term of cultural humility as the ability to, have a lifelong commitment to evaluate yourself and think about how you approach patients. And the notion is really to be willing to meet patients where they're at, and to have the ability to be thoughtful about where your patient is coming from and what story they bring to the encounter, to be able to be an effective partner, acknowledging that as a physician, we often have an imbalance of power with them. Can we advance that slide? And Dr. Betancourt over at Harvard takes it in a similar direction, that notion of cultural competency, and thinking about, rather than learning about individual cultures and their characteristics, the cultural humility approach thinks about how do we have tools and skills that enable providers to have quality care for patients everywhere, from anywhere, with whatever differences in background that may exist, and without focusing on a single culture, but integrating that culture into the interaction with the physician. Can you advance that slide? And one of the tools that we can provide to our medical students as they're learning how to interact with patients in a thoughtful way, for those of you who like acronyms, and not all of us do, the RESPECT acronym can be really useful to remind learners who are thinking about how to approach people in with a cultural humility attitude, thinking about how to establish rapport and demonstrate empathy, and think about how to be a real partner with your patients to allow that trust to develop. At the beginning of this session, before we came online, Randy and I were talking about the fact that if you have trust with your patients, sometimes you can get it wrong and your patients forgive you. And that's that really important thing in establishing therapeutic relationships with your patients, so that even if you have a discordance of cultural background or visible group association or affiliation, once that trust is there, there are a lot of things that can be said, and therapeutic alliances can further the health of patients. Can you advance that slide? So finally, thinking about what it's like to work at that clinical site, the rural site where a someone who comes from an urban background comes in and needs to be integrated in a thoughtful way, here are some tools. Here you can advance. So there's some things you can do to be set up for success. And before your learners arrive, this notion of not being that lone champion as a single provider of trying to make it work. I think it's really crucial for providers at the clinical site to educate your administration about the importance of the pipeline and why it's so important to have learners. And so if you are a physician, a primary care physician who has 20-minute slots and you've got 12 patients on your half day, asking for 4 of those slots to be 30 minutes instead of 20-minute slots decreases your patient load to 10 patients. And it allows you to really have your learner invest in the relationship with you and the learner, and really make sure that you have the time to teach your learner. And getting your administration to understand that is pretty important for you to be able to be successful. Once that's done, having your medical staff, be it your back office or your MAs or your nurse, know that they're coming and announcing that through the medical staff meetings, or having posters up at your medical site with perhaps a picture of your learner, asking your local paper if they'd be willing to write an article about the learner who's coming in with maybe a picture. That helps your patients not be blindsided when they have a new learner come in. And then once your learner is on site, make sure that you take the time, you have dedicated time to really set expectations and schedule regular check-ins. One of the reasons why learners sometimes have trouble settling in is because they're not sure what the expectations are. And I think that sometimes we rush through things hoping that someone else has done the orientation, but I think that our providers can take the time to really get to know them in a dedicated 1 to 2 hours before the actual start of their rotation. That can be time really well invested. And then throughout their stay, you want to invite them to participate in the community, not just the medical community, though that is crucial too. Make sure they're at the huddles, make sure that they're at regular staff meetings, but also social events in the community so that they understand what it's like to be a provider in a rural setting. I think that one of the things that can be confusing or disconcerting as someone who's used to the anonymity of an urban setting is, what is it like to be a provider who cares for everyone in the community, and you walk into the local grocery store and everyone's your patient, but that's not your role there. Your role is to be the shopper, and demonstrating that for your learners and helping them understand how you navigate those dual roles, where your kid's softball coach is also your patient who has stage 3 cancer, and it's not the time and the place at your kid's softball game to talk about that, but to have that be part of your relationship that's understood is something that people who come from urban settings need to have exposure to understand how that those relationships can be navigated in important ways. And then finally, once they leave, sustaining those relationships is really important, and making sure that your learners know how welcome they are to return. And that can be as simple as a Christmas card yearly, email updates on what's going on in the community, invitations back to the community, and making sure that you remain a mentor for them and you support them in their ongoing professional development. So with all that, one of the things that can arise when you have diverse learners who are working with patients who may or may not look like them is that you can have challenges. You can have confrontations. You can have explicitly racist events. You can have explicitly discriminatory events against your learners. And so I think it's really important to take that on and to own that, and to be an attending or an administrator who takes responsibility for supporting your learners. And Paul-Emile and Fernandez wrote a lovely paper in 2016 about what do you do and when there's a challenging situation where the provider is being told that they can't provide service for a patient because the patient doesn't like the way they appear or is being discriminatory. Number one, and I think this is crucial is to get back to the basics. Is this an emergent situation? Is it emergent that we treat this patient and that should determine everything else? And so they have this lovely flowchart where if the patient is unstable, you just treat them. You know, it really doesn't matter what they want or at that stage. If they're unstable, your medical duty is to treat them. And that's where, you know, as an attending, as a supporter, you can step in and do that. You can do that and then circle back with your learner and talk about what happened and debrief, etc. But the most important thing is to treat the patient. If they're not unstable, if they're stable, and this is the vast majority of cases, then it's worthwhile really talking about it. Was it really indicated for us to approach the patient and say we have to treat them no matter what if they're stable? I think we can think about whether or not that patient has decision-making capacity. Sometimes patients who are altered might not have decision-making capacity, in which case they don't have it. Then you negotiate, you figure out whether or not they need to be treated immediately if there is another provider available. But it doesn't have to be something where you have a conversation with that patient about saying you have capacity to decide you won't be treated by this person of color, this person who appears in a way that you don't like. If they do have decision-making capacity, then think about why are they requesting it. In certain cases, suppose this is a veteran who is a victim of post-traumatic stress disorder who fought in Vietnam or Korea, and there's an Asian physician who's approaching them. Will the interaction with that provider cause more harm than good? And is that something that we can think through and perhaps provide a different provider while acknowledging the experience of that learner of color and being told that they can't provide care, or that it's best that they don't? But if it's simple bigotry, if it's a patient who has a simple laceration that needs to be sutured and they are expressing bigotry and saying, I don't want to be treated by that person, it's okay. It's okay to say, you know what, you can find care elsewhere. We are serving patients who, and with the best of our ability, we deliver excellent care. All of our providers deliver excellent care. You don't get to choose who you receive care from. And so this paper is really important, thinking about the ethical ramifications of managing patients who are expressing bigotry with providers. Go ahead to the next slide. This book is really fantastic in reviewing a wide variety of scenarios like the few that I just mentioned, and it's funny because it goes back a little bit to the prescriptive descriptions of the doctor with tattoos, the Asian doctor, but in terms of the chapters that it goes through. But really what it's doing is it's exploring clinical scenarios, including things like a physician who doesn't want to speak to another physician who has a thick accent, someone who is afraid that they're going to receive poor care from a white physician because they are a patient of color. A wide variety of scenarios are explored in this book, and allows thoughtful providers, educators, learners to think through challenging situations. And when is it okay to say, you know what, you can get your care elsewhere if those are the limitations that you are experiencing. Or, no, we really need to treat you and you're going to receive care from whoever's here. And it really emphasizes the importance of taking the time to think through, the emergency of the visit, patient's capacity and the reasons for their refusal. So that's a really lovely book to obtain as you're thinking through these challenges. So finally, I just wanted to end with Holly letting you know that she had a great time when she was in a rural setting, and she really enjoyed learning about rural communities as a city dog who had fun with cows. And I, as someone who had grown up in an urban setting who received thoughtful training and education, I was able to thrive in rural settings, and for a variety of personal reasons, I'm no longer there, but I might still be there because of the wonderful opportunities I received and enjoyed in those rural settings where I worked for over 6 years. And I'd like you to, at the end of this, think about how people who you might not expect to see in a rural setting could actually thrive and do wonderful work for populations who really need them. So with that, thank you.
Well, thank you very much, Mika, for that presentation. We have maybe just a moment to answer some questions. Davis, do you want to lead this?
Sure. Yeah. And I guess given the time that we have left, I would encourage people to write their questions in the chat box, and I'll prioritize those to start. And there's a question from our colleague Dave Schmitz about international medical graduates and their inclusion in the demographic data on underrepresented in medicine. And so, Mika, I'm wondering if you could address that.
Yeah, thank you for that question. So there actually isn't that much data about specific racial and ethnic groups. International medical graduates are usually lumped a fair amount into a single category without much background to what their origin is. And so you know, it was interesting in that book I mentioned just now, when they address issues around with international medical graduates, it's mostly around how they're lumped in different categories according to their appearance, be it, you know, based on their accent, their presentation, their you know, perhaps you know, their familiarity with American terms, etc. So I think that the data is hard to parse out because of that variability in area of origin, and so a lot of this data is really hard to sort through. But I do think that it's worthwhile thinking about the fact that a lot of IMGs do end up in primary care, and a lot of them do end up in working with underserved populations. I don't have specific numbers, but there certainly is a large proportion of IMGs who end up caring for these exact same populations.
And I can add just a little bit to that, and that is that, you know, with our national data sources on physicians like the AMA physician master file, you know, race, ethnicity isn't great, that the measure in there, but it basically, you know, there's self-identified race, ethnicity, and then there's, you know, they pull from many different databases, and so that would probably be the way that that's included, those statistics on, so they are part of the, you know, they get the same racial identity or ethnic identity that the rest of us would. So I'm kind of curious about, I think the model that you displayed is really quite intriguing, and I wondered about cultural humility flipped around, you know, how educators can best deal with preconceptions, misconceptions, or stereotypes that learners might bring about rural communities and patients to the rural community learning environment, as opposed, you know, so it kind of goes both ways. And I wonder, you know, if the same principles apply, or if you have other thoughts about that.
Yeah, thank you for that question. So there's a lot of data about the bias that we bring, and the book and the scenarios that I mentioned include the bias that physicians bring, and one of the chapters is addresses a provider working with a woman from Appalachia and her resources and presumptions made, etc. I think there is a widespread acceptance of the use of implicit bias testing amongst providers to be thoughtful around what they bring to the table, and that certainly is a tool that is being used widely. So here at UC Davis, when we are placed on faculty search committees, for example, we have to complete implicit bias training. And then when we're reviewing applications for residents, we do a holistic review, which allows us to think about things a little bit beyond straightforward test scores that incorporate distance traveled, etc. And so I think, a lot of opportunities exist for learners to have that self-reflection, which is part of that cultural humility element, to be thoughtful about what we bring to the interaction and where we may be judging people for their resources. And of course, with that discordance in lived experience between an urban and a rural background, that plays out significantly when it comes to presumptions about rural resources. And so I think using that framework of cultural humility helps learners and providers to reflect on what they bring in. And there's a great study, I think it's out of Missouri, where they reviewed medical students who worked in rural settings and the presumptions they made about rural communities. And they measured that before and after exposure to rural communities, and there was a significant improvement in the prejudgment of resources and availability of activities and general predisposition to considering living in rural communities after immersion in those communities. So thoughtful immersion can help dispel some of those biases, as long as it's coupled well with self-reflection.
Well, thank you very much, Mika, for sharing with us today. And for any of those who didn't get their questions answered, we'll be forwarding those to you so that perhaps you can answer them offline. I do want to end the hour today by inviting you to our subsequent events in June and July. And as always, we're looking for topics and presenters for both our professional development webinars and our rural prep grand rounds. We also want to make sure everyone's aware of our micro research funding opportunity that's currently open until June 3rd. If you have any questions, please do contact any of us. And then finally, here's a link to the evaluation of today's event. We would appreciate very much if you would complete that. You can use the QR code to get that on your phone, or you can go to the bit.ly URL that's at the bottom of the screen. So thanks again, Mika, for presenting and for this very important topic. I think the point to be made is that even though there are some things that are true in general, when you're dealing with a patient or a particular learner, it's a particular situation, and it should be dealt with in a particular way. Throw out the assumptions and deal with both learners and patients with cultural humility. So thanks so much for reminding us of that today.
Thanks.
Thank you.